Okay. So, good morning, everybody. My name is Alberto Giachetti. I'm the project officer in the project EUniWell. EUniWell is the European University for Wellbeing, is a European alliance founded by the European Commission, and the University of Cologne is part of this alliance. And at the center of the EUniWell stands the concept of well-being, conceived for people, society, and the environment in general. Um, this is the first lecture of a series. This lecture is the title is Well-being, Health and Aging: Principles of Aging Medicine for Rapidly Changing Society of the 21st century. So this lecture, I will briefly summarize the lecture. So this lecture explores how demographic changes impact health and aging, focusing on healthy life expectancy, aging process, and societal well-being. And we'll cover the role of ethics, planetary health, and medicine in supporting healthy aging, and introduces key concepts like frailty, intrinsic capacity, and preventive care across the life course. I'll briefly present also the Professor Maria Cristina Polidori. So Maria Cristina Polidori is full professor and head of aging clinical research at the second department of internal medicine at the Cologne University Hospital. She's a specialist in gerontology, geriatrics, and internal medicine, and she has held fellowships at Harvard University, the EU Marie Curie Program, and the Robert Bosch Foundation. She's president-elect of the German Association of Gerontology and Geriatrics, and serves on the academic board of the European Geriatric Medicine Society. Her research on person-centered medicine and healthy centenarians has earned her several honors, including an Honorary Fellowship of the Royal College of Physicians of London. So, thank you very much, Maria Cristina Polidori. I hope I didn't miss anything. And I will leave the floor to Maria Cristina Polidori.
So thank you very much, Alberto. Good morning, everyone. Thank you for being here. I know that there are some German students also attending, and please be assured that I will be uploading the lecture, the slides, and also the registration of this lecture on your platform, for the learning platform at the University of Cologne. So thank you for this introduction. I'm very glad to be able to be here and to present some of the results of the current information about principles of aging medicine. And as Alberto said, for those who just came, we have a little problem with the logistics of Zoom. So in 40 minutes, or if the meeting should abruptly stop, we will get another link in the chat. And so I kindly ask you to reconnect as soon as possible. This will be a ride through many aspects of health and life. So I kindly ask you to interrupt should you have an important question something that you don't understand, because we are, as Alberto said, in the new concept, under the new concept of merging well-being in healthcare, which is not a real thing that we are acquainted with, especially in the medical sciences. So anytime that you feel like having need for an explanation, just speak up, because probably I don't see the virtual hand or your question in the chat. So just speak up and interrupt. Okay, so and also because any of your questions will be important for the registration here, so that the public in the future also hears the questions that this lecture and some of my statements will raise. Okay, so first of all, it is important to know what is aging. And we will see life is about aging. So life is about health, of course, but it is about becoming old as healthy as possible. I kindly ask Alberto Dalsas and any other participants to switch on the mic. Thank you very much, of course. And so aging is inescapable, is complex, and is heterogeneous and multifactorial. And as such, it is starting with life. Aging is part of life. And in order to have a long, healthy life, so healthy aging, we have to consider the whole spectrum, starting with birth. And in fact, starting with the phases, with the health of the mother, and possibly with the health of our parents and their families. And this health, under health, we understand a very multidimensional concept, which include intimate mechanisms of aging, even those that we don't include regularly in healthcare, and most of them are in fact neglected in routine healthcare. But as you see here, it is about modifiable genes. It is not about nature or nurture. We know that nature, so also genetic inborn aspects, play an important role in healthy aging and in a healthy life. But 75% of human genes have modifiable expressions. And most of our diseases, of age-related diseases of our time, are caused by the environment and by our own lifestyles. So if you see here on the right, it will be the whole lecture of today about things that are multidimensional: physical, economic, psychosocial aspects, life environment, and many other aspects that overall contribute to the way, to the possibility for us to become old and the way we will become old. So aging, we see that it's a process. It's not a disease. It is a process, and it's a progressive, generalized impairment of function, resulting in a loss of adaptive response to stress. So it's a kind of loss of biological reserve and in a growing risk of age-associated disease. And I'm very happy that you get these pictures and these slides, because you will see that then we will be talking about accelerated aging. And accelerated aging, which we term frailty, is biopsychosocial. It's not only biological, and it is very similar to this description. So it's accelerated aging is frailty, and aging is this progressive impairment of function. And here I will be uploading also this terminology, because every time that you talk about aging, you should know a couple of definitions very well. One is the definition of health. We will be going through it, but it is also about the definitions of life expectancy and lifespan. And those will be also, for my students in Cologne, will be also relevant for the examinations in geriatrics, because life expectancy is the average number of years that one person can expect to live when it's born, so ahead of its birth, of his or her birth, while the lifespan is the maximum length of life per species, which is a couple of days or minutes for some animals or for some insects like flies, and it is a couple of 100 years for some whales, for instance, for some kind of other living organisms. For sapiens sapiens, is 120 years, roughly, and we are working on it. As you know, there is a part of the so-called longevity science that is working about extending lifespan. Extension of life expectancy is something that occurred already. I will be showing you the impressive progress that has been reached so far. So it is about complexity, and you can imagine, for those of you, because these lectures are very interdisciplinary, for those of you who work in the lab, you will be steadily be confronted with these so-called hallmarks of aging. The hallmarks of aging are mechanisms that are associated with the occurrence and onset of aging and its phenotypes, and include some primary integrative antagonistic mechanisms such as telomere dysfunction, cell-cell communication, mitochondrial dysfunction, senescence, deregulated nutrient sensing, and many of you work on one of these hallmarks of aging. Hallmarks or pillars of aging are mechanisms of aging, are not biomarkers of aging, are not causes of aging, are mechanisms that when they are disrupted, they will be associated with the onset of aging phenotypes. And then we have a series of organ and system physiological and age-related changes, around 3,000 changes we know associated with aging. In Cologne, we established a longitudinal teaching in aging from the first to the last semester of in the medical school, so that we know what are the physiological aging changes in order for us as physicians to treat aging changes not always as pathological changes and manage them accordingly, avoiding iatrogenic conditions. And then we have the person coming to us. So the whole picture is contributing to aging aspects and the way that we age. And very often we just use the body as so the physical aspects of a person as our goal of our healthcare. But it is in fact about lifestyle, about gender issues, about socioeconomic aspects of this person, about its or own reserves, in fact, including educational reserve. So it is about complexity, the whole iceberg, and it is about as complex as these 17 Sustainable Development Goals of the United Nations are. So you see here, it is about good health and well-being, what we do in medicine. It is first of all about well-being together with health. It's not the same. They're very two important aspects. And it is also about the integration of this number 3 sustainable goal with many others. And that's why we talk about One Health and planetary health, and about this complete interconnection between different local, meso, and macro levels of our health, where we are here in our urban environments, local, with their own animals, housing, segregation, governments, the number and distribution of health providers, access to health, green and blue spaces, and food systems. But then they are really strictly depending also on the meso level of agriculture, health concepts, food industry, values, health systems, and cultures, and along many other factors. And then we have this macro environment of medical progress, migration, climate, antibiotic resistance, wars. Everything that we see today, these days, basically converges in our own health and in the health and well-being of the society. So actually, it is about complexity, and everything that we see today goes back to a revolution of the healthcare systems at the end of the 19th century, or in the mid of the 19th century, an incredible revolution of the Bismarck model with this disease-centered approach. At this time, the life expectancy was about 64 years. And here it was thought we need to protect people towards the end of life from disease with a system. And this system, which is called the biological approach to disease, in fact, saved lives, millions of lives, and enabled a revolution, the doubling of the life expectancy at birth in only less than 150 years. This was not happening until this time and will never happen again afterwards. I will show you a slide about it. So this model, it's a triumph of social and technological and medical development. In this traditional model, we use as a clinical decision-making organ dysfunction, a deficit. We give this deficit a code and we get back some money for this code. So we have an economic rewarding for this code that we give. It's a diagnosis. And we have the International Classification of Disease to give a code to the problem that this person has. So it's a deficit-oriented. We need this problem in order to make the system work. And it works sometimes looking at the comorbidities of the persons and also at chronological age. And this is a system that worked for many, many years in a wonderful way. And this system goes back to the fact that if we want to find, if we have a kidney problem, we have to look at the kidney to do kidney research and find kidney therapies or therapies against kidney diseases. The same is endocrinology for diabetes, neurology for stroke and dementia. We look at the brain, Parkinson, brain, osteoporosis. We look at, in fact, at the bone and the system, endocrinology and the bone to find out therapies against osteoporosis. So it is intradisciplinary, extremely interdisciplinary, and not really interactive until within the disciplines. And this is, of course, something that is a little bit in contrast with what we see here. And we will look at the paradigm towards the end of this lecture, that actually, if you look carefully, all of these diseases, the age-related diseases, have a sharp increase in prevalence with increasing age. And in fact, old age is the main risk factor for all these diseases. And so the idea came in the past decades worldwide, but basically a lot of research was going on in the United States on the fact that we might work on the process of aging in order then to influence the onset of all these diseases. So it's not an intradisciplinary approach like until now through the traditional biomedical model of disease, but it's an interdisciplinary approach looking at aging as the main risk factor for all age-related diseases. So what we have now a completely different world population with respect to that was there when the Bismarck model was founded. We have now, in fact, this old population, which is per se a triumph. So we are not talking about anti-aging. We are not talking about silver tsunami. This is a triumph for the society with many old persons which are biologically younger as the generations than the generations before, and bring along a lot of wisdom and knowledge that cannot be learned on 1 second and not be learned under the possibilities of AI, for instance. So it's a lot of wisdom and knowledge that the society needs on an evolutionary basis to survive in a healthy way. On the other hand, we have this population which is extremely heterogeneous. So this is the doubling of the life expectancy across geography and also time, space and time, and also the fact that this older population towards older ages gets very heterogeneous. So this progressive decline of physiological functions leading to vulnerability and risk of death is actually very heterogeneous across ages. And as long as older we get, the more diverse we get. And then I will tell you why. It is about having many, many biographical changes towards life that, coupled with our intrinsic health, will progress and produce heterogeneity. So inter-individual variability and diversity is the status quo in advanced age. And actually, age acceleration is termed frailty, and in medical constructs, we are very interested about frailty. And we also have a code for frailty, which is R54. The less we code frailty, the less we'll picture in the medical system that frailty, that this condition exists, and the less it will be recognized. So that's why in Cologne we are a training hub for this comprehensive approach to the person with disease, and not the deficit-based approach to disease, but the person with that disease. And in fact, frailty, since 25 years, is included in science and in the medical systems. But actually, what we need to include in the next few years, it is these many more aspects of aging and life, which include biological age. So another, let's say, knowledge that we think is true. We can measure our biological age. This is not true. Every organ ages at a different pace, and every person also at a different pace, so that this intra and inter-individual difference in biological age at this moment currently hinders from having a new universal metric of aging. We need to include phenotypes of preclinical changes associated with aging. At this moment, we have these 3,000 age-associated changes that we don't really include in our clinical decision-making in healthcare systems. And also multimorbidity. We have very few guidelines on multimorbidity, the concomitance, the coexistence of more than one chronic condition, and also the functional factors and lifestyle need to get part of medicine. For instance, in Germany, and in Cologne in particular, we've grounded the thorough information and curriculum on nutrition for medical students, because nutrition is a cause of many diseases and also a therapy for many diseases. So we developed in Cologne, actually not in Cologne, but we established in Cologne this well-established instrument, which is called Multidimensional Prognostic Index. It's a phenotypic clock, which includes diseases, drug treatments, psychosocial factors, nutrition, cognition, mobility, daily functions, and overall health beyond the chronological age of the patient and beyond the disease he's presenting with, and allows a 0 to 1 continuous number that measures actually the phenotypic age. We have now an app that you can download. It's free. I have no conflict of interest. It's not my instrument, and it's free for use. We established it free for use in a way that the society can monitor itself and stay healthy. You can download it in App Store under MPI-mobile, and you can, in this way, or even in few minutes, check the overall health and proxy physiological and phenotypic age beyond chronological age of your patients, for instance, and your population around you. So this is the situation. The world is getting older. The world is getting, so Europe is the oldest continent of the world, so we are getting particularly older. That's why EUniWell and the University of Wellbeing is very welcome. I will show you also in a time frame of the conceptions of health. What does it mean to work with well-being and not only with absence of disease? But actually, we're also getting more obese. So we are getting double numbers of obese persons. So body mass index above 30 in the next few years, and the population of the people above 80 years old is quadruplicating. And this is, again, not a per se the aging population a disaster. A disaster is remaining in a system that was developed for another world population 200 years ago. And actually, so we have these two unique changes of human history. Since a couple of years, more people over 65 years of age than children under 5 years of age, and actually, in fact, this explosion of obesity worldwide. And these two conditions have hidden hunger, so a poor micronutrient state leading over the years to disease without being recognized because we don't measure micronutrients in routine care. Of course, these two conditions have disease as a consequence, but also accelerated aging as a consequence. So frailty is one of the consequences, together with disease and hidden hunger, of obesity and the aging population if we don't recognize and go in health and well-being, so in prevention mode. And we will not have anymore a radical life extension in the 21st century and after. So it is expected that a peak of the population will be reached ahead of 2100, so around 2080, and not reaching the highest number that have been projected. But in any case, we will not meet the necessary requirements to have a radical life extension like that we had previously with this doubling of life expectancy in 150 years. And this is because the number of centenarians is not increasing as projected previously, and we are expecting more and more centenarians, but not as it was until now at the same pace. And this has many reasons. We cannot discuss about them today, but you are very welcome to send me an email, and I will be producing and providing real literature for you.
Sorry,
So,
Professor
yes,
Polidori, the meeting is gonna expire soon. So
yes,
I sent the new link on the chat, and I would
yes,
suggest to pass to the new link and continue the
yes.
webinar in the
So
second
wait
one.
a second, because
It's
I need to stop
okay.
here, and let's go then to the next Zoom link.
I shared
Okay,
in the chat.
thank you. Let's go over. So basically, yes. So basically, we see this increasing variability with aging, with much variability in centenarians of kidney values, for instance, while when newborns have very similar levels, all the same cutoffs. Without disease, with increasing age, we have very different cutoffs, and the same works for walking speed or thinking speed. It is about individual increasing variability with increasing age. And to look at this variability, of course, we have to move over the traditional approach of correlating two aspects. For instance, here we have a beautiful correlation between a carotenoid in plasma and the levels of a carotenoid in plasma and the ejection fraction of the heart in an older population. And this resembles very much a correlation that is known between brooding storks and newborn babies, provocatively published in Nature many years ago, or between chocolate consumption and Nobel Prize winners, also published provocatively in Lancet many years ago. The correlations that count today are multi-dimensional. A difference in about 7 years of age between East and life expectancy between East and West Germany, a direct correlation between income and frailty in Italy and also in Germany, and 30 years of difference in life expectancy between Singapore and Somalia. And so this is something that we have to consider when looking at aging and aging trajectories. It's not about only blood pressure and blood sugar or biological factors and genes. It is about multidimensional and biopsychosocial factors. And disease is different in aging because in fact, disease often presents because of the impaired reserve that we described as aging and accelerated aging, due to many factors. Even an external stressor, a new drug can improve and alter this balance of physiological reserve and go into clinical symptoms. The presentation depends from one of the weakest, so-called weakest links. So that with increasing age, the central nervous system, the musculoskeletal system, the system of balance, the system of incontinence, the blood regulatory systems. These are the 5 weakest links that we have and create atypical disease presentation in advanced age. And many findings which are abnormal in younger patients are common in older people. So it is important about knowing physiology of aging. And because also comorbidity and polypharmacy are common in older people, the symptoms are due to many factors at the same time. And this distinguishes the classical medical syndrome, which has one cause and one mechanism, for instance, Cushing, from the geriatric syndrome like instability or dizziness, which have many causes at the same time. So the multifactoriality is a hallmark of aging. And because many homeostatic mechanisms are compromised at the same time, they cannot be influenced simply if we don't diagnose them. And older patients are more likely than younger ones to suffer adverse consequences of disease, which means that we have to be comprehensive in our approach to them. So frailty was this in the timeline of the different models of this in the healthcare systems was a milestone because it improved from the aspect of looking at diseases in a separate way to look at decreased organ and system function as a whole, including the phenotype of accelerated aging as a consequence. And I need to give you a plaidoyer this time because it is important that we know that if we use frailty, electronic systems to measure frailty with existing data, if the existing data are not comprehensive enough, the electronic indexes that we will use will give us bad data back. So if we input bad data in systems, we will get bad data back. The important paradigm shift is to input in the medical systems all the main parameters that contribute to health and health maintenance, not the 1 or 2 parameters that contribute to disease. We have to switch the way to collect data. And if we don't do it, as you see, for instance, in Germany, half of the population over 65 is multimorbid, well above the European average. It is, of course, including a reporting bias because there are some systems that diagnose more and some systems that diagnose less. But still, we are not doing well in many countries. And we have to pay a lot of attention because this impacts on costs. And in fact, mortality from many diseases is decreasing because of this triumph of technological improvement. But since 2008, the first cause of mortality is multimorbidity. And for multimorbidity, we don't have guidelines because if you see that the prevalence of patients with multimorbidity, the patients with these diseases, in the majority of the cases, up to 100% of the cases are multimorbid, but over 80% of the studies on these diseases excludes multimorbid patients. So we don't have actually guidelines for multimorbidity. And the consequences are, of course, polypharmacy. So looking for interdisciplinary guidelines, we give a number of drugs per each disease, And at this point, we will have drug-drug interactions, drug-disease interactions, falls, cognitive impairment, hospitalizations, and death. And that's why accelerated aging and multimorbidity are very expensive and are very known to be expensive. And that's why we need to diagnose, even with this instrument, but not only with this instrument, with any multidimensional instrument, comprehensive instrument, which includes the person and not only the disease that this person has, we can diagnose frailty and then manage frailty through nutritional, physical exercise interventions, and then reverse towards robustness. If we don't do it, frailty, the natural history of frailty, is progress to disability. And this, once we have disability, this process is irreversible and we cannot do anything anymore. So actually we know that we can treat functional impairment, the activities of daily living and mobility through physiotherapy or occupational therapy. We can work with the pharmacists to do medication reconciliation. We can work with the neuropsychologists to control neuropsychological impairment. We can work with nutrition, with nutritionists to work on and ameliorate diet, and social services to ameliorate social impairment or socioeconomic problems. And all of these can get back to an improvement overall of overall frailty, stopping of this progress towards disability, and also being associated with much less rehospitalizations and mortality. If we don't do it, we also see here Germany again, but actually you can look at your own country in this case. This is the remaining life expectancy at 65 for women and men in the European countries, and you see that it's about 22 years. But actually up to half or over half of this time is lived with disability. So we have 12 years of disability at the end of life, which can be prevented and managed if we diagnose multidimensional frailty by a checkup that we can definitely include in healthcare systems. We have in Germany and in Italy, for the first time since last year, 2 guidelines on comprehensive geriatric assessment and comprehensive assessment in general. And we are working on the European guidelines with the European Geriatric Medicine Society. A small excursus on time, I think I will leave it, but actually it is not about length of life. This is my main take-home message. It is about width of life. It is about a broad life and not a long life. If we look only at long life, so longevity and also extension of lifespan, we might neglect the quality of life. And so I just wanted to show you that there are that the word time comes from tempus, and tempus comes from 2 Greek words which imply the concept of cutting and also of stretching. So it is about being able to work also by stretching the time in an appropriate way. And the Greek had, the ancient Greek had the chronos, the concept of chronology, and chronos, the god of quantity of time, but also the god of kairos, the quality of time, the right time, so the time that you cannot measure. And this is important to know, that extending life, especially extending genetically life span, it is about at this time neglecting the quality of life, which is of course not really important at this time. And that's why we have to pay attention at this global anti-aging market, which is increasing rapidly and tells us that you can extend your life expectancy or the length of your life without looking at the width of your life by drugs. And this is an issue and a topic that needs a lot of attention because it is a market, and sometimes also not everything that is produced there is evidence-based. So if you look at centenarians, I'm coming towards the end of this but actually, Alberto, we will have also we have time until 10:45, I think, right?
Yes.
And we also, so we will have another time that we have to switch, right? We have to
No,
switch
no.
another.
I think it's not necessary.
Okay,
We
very good.
can make it, yeah.
Okay, and actually, the centenarians, once we asked the first study on centenarians, I had the honor to participate to it, started in 1992 in Italy. And actually, we asked to the centenarians, how can you do to the healthy ones? What can you do to stay healthy until 100 years? And you can see the answer that they gave, there are many psychological answers, right? And also related to lifestyle. And many of them answer to eat a lot of vegetables and to have a very healthy nutritional habit and also lifestyle habit in doing exercise or always eating at the same time. And we looked at the biological measures of the centenarians and also of the younger family members of the centenarians. And we saw that actually the centenarians had high levels of vitamins in blood, like, for instance, vitamin A, which is not only can have antioxidant properties, but mostly biological properties related to the immune function. And if you look at the checklist today, how to stay healthy, which is also bio-psychosocial, and unfortunately still too much related to the health and wealth relationship, but still there are many biopsychosocial aspects to take into account, and some of them are new. Actually, there are many new studies. I will give you a couple of data about vaccines, for instance, or having sitting as a new smoking, a big risk factor for cardiovascular diseases. And in fact, with more than 7 hours of staying sitting a day, being a very important risk factor for cardiovascular diseases. But actually, for instance, in Germany, over 80% of the population sits more than 7 hours a day. And in this case, the physical activity, so going 150 minutes per week, or going to the sports studio, even doing a lot of sport activity, if we sit too long, it's not protective enough. So an excursus about aging as the ratio between damage and repair is the fact that we consider always aging during life as an accumulation of errors. It is one of the main theories of aging. And so accumulation of errors and entropy as the cause of aging. But actually, it is about a balance between protective factors that we have and accumulation of errors. So that all these protective factors that we input into life or that we add through interventions can balance the phenotypes that we will have when we are older and the length of our life. And this concept is defined by the WHO intrinsic capacity and tells us basically that it is about resources that you see here on the right, our intellectual, physical, financial, motivational, emotional resources that we have in life, also through our biography and lifelong learning. It is a balance with syndromes that we can produce. And if we don't include these aspects in the person-centered assessments, we will only see one part of the story and not the whole iceberg. And this is a very complex figure. We don't have to go through it, but actually we saw recently that in green, there are some resources like the social, physical, intellectual, those that I showed you just now, resources and potential that cluster together with problems with advancing age. And each of these clusters has actually a particular constellation of resources and syndromes, and has also its own prognostic profile and signature. So there are some clusters that are very dangerous for life, like those which are iatrogenic, caused by the doctors or inappropriate drug medication, because we didn't measure the person, but just the disease. We didn't treat the person, but just the disease. So we caused problems. And there are some other clusters that are not so dangerous for bad outcomes. But in any case, it is the first time that it showed that there are clusters of syndromes and resources with increasing age. So the intrinsic capacity of the WHO is a proactive model which tells you, please do consider the capacity, not the deficit, the capacity of your patients in primary care, and keep it under monitoring to keep it steady. And as soon as you see a problem in decreasing function, just act and immediately go for a treatment or prevention of the progress. It's a proactive model, which it can be summarized like this. It's called ICOPE, Integrated Care for Older People tool, but actually it is to be improved and used and implemented as soon as possible during life. And these are the domains: cognitive, mobility, nutrition, visual loss, visual ability, and hearing ability, and also emotions. And these domains, through some screening questions, can be very quickly diagnosed or evaluated in primary care, and actually constantly monitored in a way that as soon as possible, decrease in function is seen and frailty is actually prevented. And we also produce one in Cologne. It is possible to measure all these factors in our patients, just looking at their capabilities. And actually looking at intrinsic capacity, it's like a forward into yesterday, because health for the WHO, and that's why this EUniWell, this University of Well-being, is increasing so much attention and gaining so much attention worldwide, because health, it is a state of complete physical, mental, and social well-being, and not only the absence of disease and infirmity. Disease is absence of easy. And this is not only the focus of health. Health is a state of well-being, of biopsychosocial well-being. So this definition was given in 1948, and then in 1977, the biopsychosocial model of disease was described in Science, and then in the comprehensive assessment was described in 1981 in the States, and then in 2001, the WHO again described the International Classification of Functioning, the first integrated care for older people guideline in 2019, the second last year, the first CGA guidelines last year in Italy and Germany. We are in the middle of the UN Decade of Healthy Aging. So you see how much time it takes to transfer knowledge into action. The University of Well-being, which is the definition of the WHO, was also founded very few years ago. And in fact, we know from JAMA that we have an average of 17 years to transfer knowledge into action in our systems. And this is, of course, not sustainable anymore. We skip the bio break because we have some breaks by switching the links. And I will give you some information about literacy and education. So already 20 years ago, it was written also in JAMA that it is axiomatic that medical education should be there for students and educate students well and prepare them for the clinical problems they will face in their future practice, which is chronic disease. But actually, we still use the medical education system of acute disease, and also in the healthcare systems, we still focus on acute disease. And so the need for a new clinical education in 2004 was actually showing already from non-geriatricians the need of caring across settings, educating patients in self-management, visit in which the topics are often chosen by the patients, multidisciplinarity and shared management, telemedicine, using relevant behavioral science concepts and methods to understand the adverse effects of disease on patients' life. And all of this was actually published in Lancet in 1946 by the mother of geriatrics and aging medicine, a British female surgeon, Marjorie Warren, who was assigned an hospital with 800 chronic ill patients at that time in the UK and also in other languages. They were called inmates, so prisoners, because they wouldn't be managed until they would die. And she decided to classify them, all of them, and she defined the classification between of these patients among chronic up patients, chronic continent but bedridden, chronic incontinent patients, senile but quiet, and senile but disturbing. So showing the importance of functions of these patients and not of organ disease. And this was a revolution, in fact, the revolution that led to the establishment of the medical specialty. But actually, this is only possible to look at the person and to do this goal-oriented, person-centered, value-based medicine if we have enough literacy. And actually, you see that many countries in Europe have a very low or a very high percentage of the population of adults or persons between 16 and 65 with literacy difficulties. And literacy difficulties include health literacy difficulties. And that's why we have these high numbers of multimorbid persons. So everything should be made as simple as possible, but not simple, not simpler, as Albert Einstein used to say. And we need to educate the population and also pre-graduate and postgraduate students, and not only the medical students, but across disciplines, with also transversal skills for the health workforce of the 21st centuries, including skills for personalized care, for creating a positive work culture, and everything that increases the person-centered approach. And so in this sense, we have many educational activities, particularly in Cologne. And one of these is a highlight, the EUniWell. We are working together also with the University of Florence, of Murcia, of Nantes, of Semmelweis, and Santiago de Compostela, to work on establishing and launching. We are launching a master for well-being in healthcare, a professional master for well-being in healthcare, providing all these skills and information for the future health workforce. People who understand and are able to include in their own practice that it is not about that the majority of diseases are caused, as you see here, by lifestyle, bad lifestyle. So 70% of disease, of age-related diseases, is caused basically by ourselves. And actually, we don't like to change this way. So we need the healthcare workforce able to motivate the population to change and to adopt healthy lifestyles. The outlook, and then I will conclude now. We have in Cologne this the largest worldwide cohort for patients measured by the multidimensional prognostic index, evaluated as persons and life, and not only as disease. And we termed this cohort with 4,000 patients seen longitudinally across different sectors, everywhere in geriatric hospitals, in normal hospitals, in the community dwelling environment, emergency department, internal medicine, neurology, psychiatry, surgery, and so on, urgent care also. And we called it Kairos to, in fact, point out at the individual and dynamic nature of aging. And we showed in many years that the geriatric syndromes, resources, and their profile have different prognosis, that CG comprehensive tools predict quality of life, not only the quantity of life, but also the quality of life, that if you look at the person, you will be able to do your diagnosis more precisely than if you look only at the physical aspects, at the body of this person. That intrinsic capacity, so the maintenance of functions, is better to sustain clinical decision making than looking at bad prognosis of patients. That the complex rehabilitations ameliorates this phenotypic age of our patients, is associated with less rehospitalizations and less mortality. That self-esteem and self-efficacy are independent outcome predictors. So these psychological aspects are important to measure in the world population of the 21st century. And that it may be, it looks like this phenotypic person-based clock can discriminate the physiological relevance of many clocks. And here I'm very happy to tell you that the CICA, the Excellence Center in Cologne for the study of aging and age-related diseases, got in the next funding period of the German the German Foundation Research, the DFG, for more years. So we are able now to study better the translational aspects of aging clocks, metabolomics, transcriptomic, or proteomic clocks. And so to go again into this summarizing time frame of many disease models, we see that we started with the Bismarck model, looking at very different aspects, the diseases itself, and looking at interdisciplinarily where is the disease and looking for the treatment. We saw that the concept of frailty was introduced to actually improve the understanding that aging is overall process concerning many diseases and organs and systems in the body. Intrinsic capacity produced the positive concept of maintaining functions instead than diagnosing deficits. And we are now moving in an exciting field published in Science Advances a couple of weeks ago, called intrinsic health, and basically showing that we are all born with a special amount of intrinsic health that then it's filtered about the prisma, the lens of the context, the prisma of life, and converges in many health and disease trajectories. And we can actually maintain and influence the structure, energy, and function of intrinsic health also by maintaining intrinsic capacity. We are working on this, but actually at this time it is important that frailty concept is maintained in the healthcare systems because it enables person-centered medicine, and also intrinsic capacity is located in primary care and to empower primary care and general practitioners and primary care physicians to maintain the population at the high vitality level. because the youngest baby boomers are retiring, and that's why we will have several 100,000 vacant positions in the next few months. Then we are producing avatars and robots that are able to collect the person-based information and hybrid interaction with physicians. So not robots that substitute doctors, but robots or avatars that are able to, through chatbots, to interact with the patients, collect these person-based numbers and biological or physiological age, phenotypic age measures, and also transmit them to the doctors. And last but not least, the concept of geroscience is that if we look at disease pathophysiology and aging physiology together, and we try to improve the phenotypes of aging, then we will at the same time control all age-related diseases. And this is important for you, this concept of geroscience, to know that working and maintaining a healthy aging process, it means to decrease the chance of diseases. And in fact, we can, if we do prevention, we could avoid 80% of cardiovascular diseases, 50% of dementia cases, and 40% of cancer cases. Vaccines are a beautiful example. If we improve our health, our immune system, we will be able, by influenza or zoster vaccines, to decrease the incidence of dementia and stroke, for instance, because immune senescence is one, with inflammation, one or two of the main pillars of aging. And vaccines reinforce the immune system and decrease senescence of the immune system. And multimodal interventions or metabolic drugs are not able only to decrease cognitive impairment, but also neurodegeneration, obesity, diabetes, cardiovascular, because there are common mechanisms of aging that can be acted and modified at the same time to decrease the phenotypes of aging. So I am now finished with my lecture, and I hope that I could convince you that there is a development in the world population that needs attention, because the characteristics of the world population are getting different and need a paradigm change in the healthcare system, which is not deficit-oriented, but person-centered, and includes the maintenance of functions and does not reactively only diagnose deficits and diseases. So prevention and education are the main pillars of healthy aging at this time and are multidimensional, bio, psycho, social. Thank you very much for your attention. I will stop the sharing and will be welcoming your questions if you have any.
Okay, thank you very much, Professor Polidori, for this very interesting and inspiring lecture. I noticed with the time that the meeting will expire, also this meeting. So I suggest to pass to a third meeting, I'm sorry, for the question and answer session.
Yes.
I send the link on the chat, and we pass to the third session.
Very
Sorry
good.
for the inconvenience.
No problem.